Welcome. Today we're diving deep into Alpha-1 antitrypsin deficiency, or ATD. This inherited condition can significantly impact the lungs and liver, and understanding it is crucial for early diagnosis and management. So, what causes AT? It all boils down to a genetic mutation. Alpha-1 antitrypsin is a protein primarily produced in the liver. Its main job is to protect the lungs from damage caused by enzymes like neutrophil elastase, which is released by white blood cells to fight infection. In AAT, a defective gene leads to the production of abnormal or insufficient A8 protein. Let's delve into the pathophysiology. Because the abnormal A8 protein can't be properly released from the liver cells, it accumulates there, potentially leading to liver damage, including cirrhosis. Simultaneously, the lack of sufficient A8 in the lungs leaves them vulnerable to the destructive effects of neutrophil elastase. This can result in emphysema, a progressive lung disease characterized by the destruction of air sacs. Epidemiologically, ATD is estimated to affect about 1 in 3,000 to 5,000 individuals of European descent. However, many people with AAD are undiagnosed. It's important to note that the prevalence varies among different ethnic groups. What are the signs and symptoms of AAT? Well, they can vary widely and often don't appear until adulthood. Lung-related symptoms include shortness of breath, wheezing, chronic cough, and frequent respiratory infections. Liver problems may manifest as jaundice, swelling in the abdomen, and fatigue. Some individuals may also experience skin problems like panniculitis, a painful inflammation of the subcutaneous fat. How is AAT diagnosed? Typically, diagnosis involves a blood test to measure the level of A8 protein in the blood. Genetic testing can then confirm the presence of the specific AD-related gene mutations. Pulmonary function tests and liver function tests can also help assess the extent of lung and liver damage, respectively. AT has several classifications based on the specific gene mutation. The most common is the PZZ genotype, which is associated with the most severe deficiency. Other variants, like PMZ or PPSI, can also cause AT but may result in milder symptoms. Understanding the specific genotype is crucial for predicting disease severity. Treatment for AT focuses on managing the symptoms and preventing further damage. For lung disease, treatment includes bronchodilators, inhaled corticosteroids, and pulmonary rehabilitation. Augmentation therapy, which involves intravenous infusions of purified A8 protein, can help protect the lungs. For severe liver disease, a liver transplant may be necessary. Lifestyle modifications, such as quitting smoking and avoiding environmental irritants, are also crucial. While there's no direct way to prevent inheriting ATD, genetic counseling is recommended for individuals with a family history of the condition. This can help assess the risk of passing the gene on to future generations. Additionally, avoiding lung irritants like smoke and pollutants can help slow the progression of lung disease. The prognosis for individuals with ATD varies depending on the severity of the condition, the presence of other health problems, and adherence to treatment. Early diagnosis and intervention can significantly improve outcomes. Current research is exploring gene therapies and other novel treatments to improve the lives of those affected by AT. We are also learning more about how ATD might increase the risk of other health conditions, such as certain cancers. Staying informed and working closely with a healthcare team are essential for managing this complex condition effectively.